pacing, after his bundle pacing, is the left bundle branch pacing. So today we are going to have the concluding session of the demystifying conduction system pacing. Let me tell you that Dr. Shunmuga has very beautifully and he's gone very slowly to elaborate on all the underlying principles and the ways and the techniques to do this particular procedure. So I have a great privilege in welcoming my colleagues, Professor Sumodh Kurian, Professor of Cardiology from G. Pant Hospital. I have great privilege in welcoming Dr. Ankit Bansal, Associate Professor of Cardiology from G. Pant Hospital. And along with both of them, we have Shunmuga Sundaram joining us again for his second lecture. So over to you, Dr. Sumodh, to welcome Dr. Shunmuga and start the session.
Once again, a very warm welcome to today's PG Track program. We had a very simple and a very lucid teaching by Dr. Shunmuga on his bundle pacing and the basic intracardiac electrograms. It was a very good lecture, and even non-EP people could very easily understand that teaching. So today also, I am sure everyone is very eagerly looking forward to hear about left bundle branch pacing, how to do it, and we welcome Dr. Shunmuga. Please come and teach us. And Dr. Shunmuga, as you know, he's the associate professor at Vellamal Medical College in Madurai, and he's an expert in this field. And welcome, sir, and come and teach us on LBB pacing.
Thank you, sir. Once again, I'd like to thank CSA Delhi chapter for providing me this excellent opportunity. So, as an extension of the previous week's talk, so where we have discussed about the intracardiac electrograms and what are the basic principles of understanding these electrograms for doing physiological pacing. And in the second part, we have discussed about His-bundle pacing, the techniques, and its clinical implications. And today, we'll discuss about another dimension of conduction system pacing, is otherwise known as left bundle branch pacing. So in this talk, I'll be discussing about the relevancy of left bundle pacing with its difference between the His-bundle pacing, and what are the clinical implications, and what are the scientific evidence so far we have regarding this innovative way of capturing the cardiac conduction system. So last week we saw how to do this His-bundle pacing, where the lead will be screwed at the distal end of the His-bundle after analyzing the disease-free zone. So today we'll be discussing how to capture the left bundle branch fibers, which will be on the other side of the interventricular septum. So obviously we are going to do it from the right ventricle. So we have to go deep into the interventricular septum to capture the left bundle branch fibers. So any scientific terminologies need some definitions. What is the definition of left bundle branch pacing? It's defined as capturing the left bundle branch, either its main trunk or one of its fascicles, like you can capture the anterior fascicle or even the posterior fascicle, along with the septal myocardium. So we know that the fibers are embedded in the septal myocardium. So we'll be capturing the surrounding myocardium also. And the captured threshold will be less than 1 volt at 0.5 milliseconds. Remember, when we discuss about His-bundle pacing, so we were discussing the captured threshold at 1 milliseconds pulse width. That is quite abnormal for a normal pacemaker, because normal pacemakers, we usually check the pulse width at 0.4 milliseconds. So here in left bundle branch pacing, we usually measure the pulse width or capture threshold at a pulse width of 0.5 milliseconds. So it's defined as capturing the left main bundle or one of its fascicle along with the septal myocardium at a low output. There are certain criteria to confirm that we have captured the left bundle. The first and foremost is going to be the paced QRS morphology. See, we are capturing the left bundle. So the left bundle will be pre-excited and the left ventricle will be activated first, followed by the right ventricle. So whenever you are pacing the left bundle, it is clearly a scientific evidence that you will create a right bundle branch conduction delay in the ECG. So getting an RBBB delay pattern in ECG is a must for demonstrating LBBB capture. So you must have a QR or RSR pattern in lead B1. So that is must. Apart from that, you have to demonstrate one of the other 4 following criteria. One is demonstration of left bundle potential. So I've shown that whenever you're placing the catheter across the His-bundle, you'll be seeing 3 deflections. One is the atrial deflection, second one is the His-bundle deflection, and third one is the ventricular deflection. So this his bundle deflection is because of activation of the his bundle fibers. Similarly, when your lead is placed in the left bundle area, your left bundle activation will produce a potential which can be easily captured by the pacing lead. So demonstration of left bundle potential is one such criteria. And we have to measure peak left ventricular activation time. What is that? It's a very simple measurement. So while pacing, after capturing the left bundle, you have placed the lead in the left bundle zone, and you have to pace and measure the interval between the pacing spike to the peak of R wave in lead V5 or V6. So that is known as peak left ventricular activation time, and it should be preferably less than 80 milliseconds. So you have to measure the onset of interval between the onset of pacing spike to the peak of R wave. So that duration in lead V5, that duration should be less than 80 milliseconds. A demonstration of non-selective to selective capture. So in the previous section about his bundle pacing, so we have shown that we can demonstrate on the surface ECG about this selective capture of his bundle and non-selective capture of his bundle. Similarly, you have to show here that you have a transition of non-selective to selective capture of left bundle. So you can see it from the surface ECG as well as from the intracardiac electrogram. So I'll show you how to see that non-selective to selective capture. And of course, the fourth one is a little electrophysiological terminology. So you have to perform a programmed deep septal stimulation to show the refractory period of left bundle. So this is a little complex. I think probably I will take away this point for time being. So you have to have this QR or RSR in lead V1, that is must. Apart from that, you must have one of the other four following criteria to demonstrate that you have captured the left bundle. So not all deep septal pacing is going to be a left bundle branch pacing. So you have to have this criteria satisfied to label that you have captured the left bundle. The gadgets are the same. So these are the gadgets which we usually use for doing his bundle pacing. The same gadgets we are going to use, the C315 his catheter or otherwise known as sheath, and the 3830 Medtronic lead, 4.1 French MRI compatible luminous lead, which we usually use it for doing his bundle pacing. So for the beginners, if you want to go through review articles, this is someone which I published recently in JCE about implant techniques and its clinical implications. So here we have all how to do the procedure, what are the clinical implications, how to do the troubleshooting in patients who have difficult implantations. So this is a typical EP lab setup. This is in fact the same for doing a his bundle pacing also. So you need to have an EP system as well as the fluoroscopic screen in front of your eyes while doing the procedure. And the PSA will be there to assess the lead parameters. And this is the catheter which I've shown you. So the same his catheter which we are using for doing his bundle pacing. And currently there is one catheter available, which is a non-deflectable C315 sheath. And typically it is an infraclavicular incision along the line below the clavicles. And we usually take an extra thoracic left subclavian puncture. And I usually take two punctures separately. I never used to mix up both in the same puncture. So once the two punctures are taken, so the upper one will be used for atrium and the lower one will be used for ventricle, so that your final lead positioning will be better if you are taking in that way. So for putting the sheath, like the his bundle where I was describing, that you have to always have the 7 front sheath in situ, and over that is always better to put your C315 sheath so that you can have a good control whenever you want to reshape the sheath. So I'm just putting the sheath in. So you can see here, once the sheath in, and till this point, the procedure is almost the same, like doing a his bundle pacing. So in his bundle pacing, your sheath will go to this his bundle zone and you will start mapping and screw the lead wherever you are getting a good his signal as well as the ventricular signal. But here in left bundle pacing, so you have to take the catheter from the right atrium and go into the ventricle. So this is the first term which differentiates his bundle pacing from left bundle pacing. So in the left bundle pacing, you have to take the catheter or his sheath into the right ventricle, and you have to keep it probably 1.5 centimeter below the distal his signal. So here I wanted you to know regarding certain anatomical thing which will help you in deciding the site of implantation. So I've told you, like, you have to take the sheath just below the his bundle catheter. So imagine this is your his bundle catheter, quadripolar catheter from the groin, and this is your distal most His signal, which will be getting in the EP system. And this is your RV apex. So we will always have a catheter in the right ventricular apex to have a backup pacing, as well as to tell you that this is going to be the RV apex. So you have to draw an imaginary line connecting the distal His catheter towards the RV apex. And our working zone is going to be the initial 1.5 centimeter. So this is the area where you'll be targeting. So this is the rough anatomy of the conduction system in RAO view. So this is going to be the His bundle, and this is the left bundle, this is the right bundle. And the left bundle in turn divides into posterior fascicle and anterior fascicle. So you are targeting the left bundle, which though it is on the other side of the septum, in RAO view, it will not differentiate whether you are facing anterior or posterior. It will just tell you whether you are just towards the RV apex or towards the base of the right ventricle. So here you have to place the sheath just below the His bundle catheter, probably 1.5 centimeter, along an imaginary line connecting the distal His signal towards the RV apex. What next? So then take your lead inside and just expose the tip of the lead outside the sheath. So here, this is going to be your cathode and this is going to be the anode. So the anode will be still within the sheath. So you're just going to expose the cathode of the lead or just the helix of the lead, probably 1 to 1.5 millimeters just outside the sheath, and place it on the right ventricular side of the septum. So imagine this is the septum and this is the right ventricle and this is the left ventricle. You just have to expose the lead out and do pacing. See, we are not screwed here. We have just exposed the lead on the right side of the interventricular septum, 1.5 centimeter below the distal His signal, otherwise known as a basal septum. And you have just exposed the lead, then do a pacing. Since the anode is still within the sheath, you have to work in a unipolar mode of pacing maneuver. So once you pace, you have to see lead V1. So in lead V1, if you are going to get a W pattern and lead 2 positive and lead 3 biphasic. So if you are going to get this paced morphology, that means that you are just opposite to the left bundle area. That means that you are at the right side. So once you see this W pattern in lead V1 and a positive QRS in lead 2 and probably a biphasic QRS in lead 3, then that should be the target side. So once you have reached the target side, so you have to shift your fluoroscreen from RAO to LAO. While doing screwing technique, while doing the screwing, we always prefer to screw in LAO view because that will tell you how beautifully the lead is going into the septum. See, our conventional septal thickness of a normal adult Indian population is going to be somewhere between 9 to 10 millimeter. So your left bundle branch fibers are on the subendocardium of the left side of the interventricular septum. So you have to go almost 9 to 10 millimeter inside the septum to reach the left bundle fibers. So you have to go at least 9 to 10 millimeter inside the septum with the lead. So you have to give rapid turns so that the lead will go deep into the septum. So while giving turns, after each turn, you can see the paced QRS morphology. And what you can see here is, so once it is on the right side, it shows a W pattern. And once the lead gradually goes in, you can see the notch of the W gradually ascends up. And once the lead reaches the mid septum, the notch, it almost reaches that isoelectric line of the QRS segment. And once you give further more turn, it almost formed an isoelectric line. And once you reach the left bundle area, so that is going to produce a R wave. You can see here, this notch has gradually ascended up and it has almost produced an R wave once the lead reaches the left bundle area. So that is our target. So that's what I was talking. So you need to have a QR pattern in lead V1. So this is lead V1. So we got a QR pattern. So once this QR pattern is reached, you have to stop screwing. So that is our target. So we have captured the left bundle. So once it's reached, just stop pacing and see the lead electrogram. So this is the lead electrogram. So in His bundle pacing, we'll be seeing a atrial signal, His bundle signal, and a ventricular signal. Here, since you are far away from the atrium, you are into the ventricle, so you'll not be able to see an atrial signal, but you'll be able to see a left bundle potential and a local ventricular electrogram. So this means that your lead is right on the top of the left bundle fibers. So you got a left bundle potential as well as a local ventricular electrogram. So when you measure this interval So in his bundle pacing, we measure the interval from the onset of the his bundle his signal or his potential to the onset of the surface V, which is usually between 35 to 55 milliseconds. Here, so we have to measure the interval from the onset of the left bundle potential to the surface QRS. This will be usually between 15 to 25 milliseconds. So this is how we usually do the left bundle branch pacing. See here, so I've kept the lead on the right side of the septum. So I'm almost preparing myself to do screwing. In left bundle pacing, so the screwing is little difficult, and you have to learn it to do it so that the lead tip as well as the body has to go deep inside the septum. See here, it's not only the helix, your whole body of the lead has to go in. So your rotation should be very rapid, and the rotation should be effectively transmitted from the one end to the other end of the lead. So what I usually do is, I usually have this lead perfectly dry and my hand also perfectly dry, so that whatever turns I'm giving, it will be effectively transmitted to the other end of the lead. So see here, so once I'm comfortable that I'm going to screw in the particular area, see still my fluoro is in the RAO view. So once I'm ready to screw, I usually remove my glove and wear a fresh pair of a single glove, and I will move my fluoro screen to the LAO zone. And you can see here, so I usually use two hands, and the sheath will be actually kept in the counterclockwise torque by a second operator. So usually my scrub nurse will keep the sheath with a counterclockwise torque, and I'll use both my hands to give rapid turns. You can see how rapid I'm giving the turns. And if you are giving rapid turns, you can see here how beautifully the lead is going, just like a trace of a bullet into the ventricular septum. So you can see here lead, how fastly it goes into the septum. So once it reaches the target zone, we'll stop screwing and measure the parameters, both the pacing parameters as well as the pace QRS morphology. And if you are satisfied, then we'll not give further turns and we'll strip away the sheath. So you can see the left bundle potential in a magnified way here. So this is a sharp left bundle potential from the pacing lead, and you can see the local ventricular electrogram. When you measure the interval from the left bundle potential to the onset of the surface QRS, it will be between 15 to 25 milliseconds. And regarding the peak left ventricular activation time, I've told you that we have to measure in lead V5. So from the onset of the pacing spike, usually the pacing artifact will be seen very well. So from the onset of the pacing artifact to the peak of RVM in lead V5. So if you are going to measure it, and if it is less than 80 milliseconds, that means that you've captured the left bundle. You can see here the lead V1 has a QR morphology, and the peak left ventricular activation time is less than 80 milliseconds. The pace QRS is around 100 milliseconds. So once it is done, we can do an angiography using probably 1 to 2 ml of contrast to show how deeply you have entered into the septum. Just see here. So this is the contrast which staining the septum. This is a contrast staining the septum. So this is an LAO view. So this is going to be the septum. This is left ventricle, and this is your right ventricle. So your lead has gone almost 13-14 millimeter into the ventricular septum. So only if you go deep into the septum, depending upon the patient's septal thickness, you'll be able to capture the left bundle fibers. And regarding this non-selective to selective, so in his bundle pacing, we can clearly see on the surface ECG that isoelectric line from the pacing artifact to the onset of the QRS, because the interval is going to be at least 40 milliseconds. We know 40 milliseconds is equal to one small box in the ECG. But here, the isoelectric interval is going to be hardly 15 to 25 milliseconds. So it will not be seen on the surface ECG. See, surface ECG, at least one small square, you need to have some change, I mean a magnitude of change of at least one small square to see it visibly. But here it is going to be only 15 to 25 milliseconds. That is the actually interval between the left bundle potential to the QRS. So that will not be seen in the surface ECG as an isoelectric line. But you can see here in the local electrogram. So here, this is the local electrogram, lead electrogram. So the lead electrogram, while discussing the his bundle pacing, we discussed that the lead signals will be bifurcated. One will be going to the EP system, and another one will be going to the program analyzer, system analyzer. So here I bifurcated the signal. One is actually connected to the EP system. So from the EP system, you can see the local electrogram. And while pacing, you can see the pacing artifact is immediately followed by the local ventricular electrogram while having a non-selective capture. But once the capture has become selective, the lead pacing artifact is followed by an isoelectric interval, and then the local ventricular electrogram usually appears. So this difference, you can see the visible difference here. This is a non-selective capture where there is no interval between the pacing artifact and the ventricular electrogram. But here, there is a clear interval from the pacing artifact and the local ventricular electrogram. On the surface ECG, you can very well appreciate here regarding the change in QRS morphology. So you see here in lead V1, it is a QR morphology when there is a non-selective capture, but it is changing into a small RSR once it has become a selective capture. This subtle change in QRS morphology can be appreciated if you are going to increase the sweep speed of the ECG. See here the sweep speed is 150 millimeter per second. Our routine ECG, the sweep speed is going to be around 25 millimeter per second. But here in the EP system, we usually increase the sweep speed to 150 millimeter per second. What about non-EP setup? So people have started doing left bundle branch pacing in non-EP setup. So in fact, having an EP setup will give you much of a comfort zone so that you'll be able to do the procedure in a near perfection. But in those areas where you don't have an EP system, still you can do a left bundle branch pacing using a 12 lead ECG and a running monitor where you can see, or a cardiac monitor where you can see the ECGs in front of your eyes, and a program system analyzer. So this ECG will give you the QRS morphology, where we need to know whether it is QR in lead V1 and what about the other leads. And the program system analyzer will tell you whether you are able to see a potential, like here where you can see a sharp left bundle potential before the ventricular electrogram, as well as a change in non-selective to selective. See here the artifact is immediately followed by a ventricular electrogram. Here the artifact is followed by some interval and then the local ventricular electrogram. So with a 12 lead ECG and a programming system analyzer, still you'll be able to do left bundle branch pacing without an EP setup. But for an optimal result, for an excellent result, you need to have an EP system in hand to have a good paced QRS morphology. Of course, we can use an 3D system, 3D mapping system. I hope you understand what is a 3D electrodynamical mapping, where either an EnSight or a CARTO system can be used to create a three-dimensional geometry of the chamber of interest. So here we are going to pace the proximal septum below the His bundle and the right atrial appendage. For atrial lead, we usually place the lead in the right atrial appendage. So what you have to do is you can create the three-dimensional geometry of both atrium as well as the proximal ventricle, and you can mark the His bundle signal. So these red dots are His bundle signal. So once everything is marked, all you have to do is take your lead and then go into that specific area. Your lead will be very much visualized. You can see the pacing lead here, and that will tell you where you are, what is the relationship of the lead to the His bundle signal. And you can just go 1.5 to 2 centimeters below the His bundle signal and capture the left bundle so that you can effectively reduce the fluoroscopic time. So this particular case, which you published in JACC-EP, the total fluoroscopic time was just 86 seconds. And we could finish off the procedure with a fluoroscopic second of closely 1.5 minutes without exposing much radiation, both to the patient as well as to the operator. Of course, even in pediatric population, we can do the procedure. So this was a 13 years old kid with a congenital complete heart block. We know all these kids and young congenital complete heart blocks, they are going to have pacing for their lifetime. So if you are going to capture the conduction system, either His bundle or left bundle, that is going to have a synchronized activation of the ventricles, and that is going to avoid all pacing related complications. So of course, the most benefited people, of course, in a CHP group is going to be this population, because they are going to have a lifelong ventricular pacing. So if you are going to have a conduction system capture in this population, definitely you can avoid all the pacing related complications. So recently we have come up with one more idea of capturing the left bundles. So far, the technique is to give turns, see the QRS morphology, give one more turn, see the QRS morphology, see how the notch is going up and producing an R wave. But what we usually do is we give rapid turns. So while giving rapid turns, since the lead is rapidly moving into the ventricular septum, while moving it generates PVC. It's because the lead is actually rapidly moving, and the ventricular myocardium, because it is having, because it is irritating the ventricular myocardium, that generates PVCs. So what you do is, we're giving rapid turns. We usually observe the change in QRS morphology of the paste of the VPCs. You can see here, this is a baseline LBBP, and we have started giving turns. So once the turns have started, the lead is generating VPC, and you can see the gradual change in VPC morphology. And once I reach the particular area where I can get an RSR pattern or a QR pattern of VPC, I usually stop giving further turns. That means that this area, you can see that even the QRS duration, this is a baseline QRS duration. Once my lead is traversing into the wet septum, there is a gradual reduction in QRS duration. And you can see once the PVC morphology has become RSR, and you can see the QRS duration has come down. So I usually stop giving further turns. When I see the parameters, when I see once all this satisfied criteria is satisfied, I can confirm that the left bundle is captured. So that means that I need not have to give turn by turn. I just have to give rapid rotation and see for the pace that generated VPC morphology. So once I get this RSR pattern, I usually give stop further turns, and we can see the pace QRS morphology, and that will confirm that I've captured the left bundle. So this is yet another way of capturing the left bundle by observing the PVCs which is getting generated during the implantation technique. Of course, it has a lot of other benefits. Since in a physiological pacing, we are going to activate the normal cardiac conduction system. Sometimes the pathological QAs which are masked by this left bundle branch block pattern can be regenerated. So this particular patient had an old inferior LMA. He had a stent. She had a stent in an RCA, and subsequently he developed this LBB related cardiomyopathy. So once we did a left bundle branch pacing, we could see that his Q waves are regenerated, and his normal physiological activation is restored. So that means that your left bundle branch pacing is going to help in bringing out the hidden pathological Q waves because of activating the normal cardiac conduction system. So far, we have seen the use of left bundle branch pacing in patients with a congenital complete heart block, but the most important is going to be an alternative modality for cardiac resynchronization therapy. So this left bundle branch block in a non-ischemic cardiomyopathy patient, if you are going to capture the left bundle in a proper way, you'll be able to get a almost normal appearing QRS. So what surprising thing which we noticed was almost always, if you are capturing the left bundle in a probably a non-ischemic cardiomyopathy with an LV dimension of less than 60 millimeter, many times their LV function is going to get reverted to normal probably in a period of 1 to 2 months. So whatever be the size of LV, even if the LV dimension is more than 70 millimeter, we can capture the left bundle and produce a QRS of almost 100 milliseconds. And the most important thing is acute improvement in the hemodynamic benefits. You can see here, this is a baseline echo showing a global LV hypokinesia with a trace pericardial effusion due to heart failure. And this is after 7 days of implantation. So within 7 days, you can see how beautifully the contraction has improved. We didn't do anything, just screwed the lead in the left bundle, put on lead in the HCM, connected to a dual chamber pacemaker, and how beautifully the contraction has improved from an ejection fraction of close to 25% to an ejection fraction of close to 45% in a period of 7 days. And even a mitral regurgitation, so surprisingly, the mitral regurgitation, which was close to 3+ before procedure, has been reduced to close to 1+ immediately after 7 days after implantation. So this acute hemodynamic benefit has been documented in bundle pacing, and now we have documented this thing even in left bundle branch pacing. So this physiological pacing, if you are going to correct the electrical abnormality, the conduction is going to improve very rapidly. Unlike CRT, where we could see this improvement, we could see this improvement in a conventional IV therapy, but it takes at least 2 to 3 months for seeing a visual improvement in LV ejection fraction. But here you can see within weeks if it is going to be a typical non-ischemic cardiomyopathy. Not only LBBB, even a dilated cardiomyopathy with an RBBB morphology can be corrected by doing a left bundle branch pacing. This is slightly a confusion because we know that capturing the left bundle is going to produce a RBBB delay pattern. So even in patients with an RBBB, if the QRS duration is very much widened, we can still narrow down the QRS. Like this patient who had a baseline QRS of 160 milliseconds was narrowed to almost 100 milliseconds. And again, we could show that there is a significant improvement in ejection fraction. So not only LBBB, even in patients with an RBBB, we can clearly show improvement in terms of LV contractility, LV ejection fraction, and NYHA functional class if we are going to capture the left bundle. This pace and ablate strategy for patients with fast ventricular rate and atrial fibrillation has been there for a long time, but people are not doing it because it is like creating one disease, RV pacing complications, for treating one disease, AF with fast ventricular rate. So for treating AF with fast ventricular rate, we are going to ablate the AV node and pace the right ventricle So the pacing the right ventricle is going to produce a lot of complications. So it's like creating one disease for treating one disease. So people are not doing it that frequently. But with the advent of physiological pacing, both his bundle as well as the left bundle pacing, so we started doing it for many of the patients. We have found beautiful results. This particular lady with a permanent AFib for almost a year landed up with us for heart failure management. Her LV was down close to 35%, and the rate was very rapid despite giving amiodarone, kilaptin, digoxin, all these rate control drugs were given. Despite that, the rate was very high. So what we did was we just simply screwed the lead in the left bundle zone and ablated the AV node. So here, ablating the AV node will avoid a fast ventricular response, and capturing the left bundle is going to produce a normal appearing QRS. So you can see the paced QRS. The QRS duration is hardly 100 milliseconds. You can see it's a QRS almost normal. So you have effectively controlled the rate by ablating the AV node, and you've given a rate of 80 or 70 for the patient by capturing the left bundle. So this is not going to produce all the RV pacing related complication, but it is going to reduce the pill burden of the patient. It is going to improve the ejection fraction of the patient because you are capturing the conduction system. The LV function is going to improve. And since because you have ablated the AV node, you will not have the fast ventricular rate. So you not have to give this all high dose amiodarone, high dose kilaptin and digoxin for controlling the rate. So needless to say, the patient's ejection fraction improved to 60% within a matter of 15 days once the rate was controlled and left bundle was paced. Remember, not all left bundle pacing is going to generate a narrow QRS. Sometimes in patients with an end-stage disease or a burnt-out disease where your left ventricular dimension is going to be huge with a depressed LV and recurrent heart failure and sometimes ischemic DCF, your left bundle pacing will not narrow down the QRS. Like this patient where the baseline LBVB QRS duration of close to 220 milliseconds was narrowed down to 140 milliseconds by left bundle pacing. So left bundle pacing is not sufficient because with this QRS duration, definitely you cannot leave the patient because his LV is not going to improve. So we need to have one more companion. So we know that there is one more option, or probably a good option, what is known as a conventional IV therapy. So you can put one lead in coronary sinus. So this is a coronary sinus lead pacing where you got a QRS of again around 160 milliseconds. So you have a coronary sinus lead, which is producing a QRS duration of 160 milliseconds. You have a left bundle pacing lead, which is producing a QRS duration of 140 milliseconds. But surprisingly, when you pace both this together, we got a QRS duration of 110 milliseconds. So we have effectively reduced the QRS from 220 milliseconds to close to 110 milliseconds. And definitely with an LV dimension of 80 millimeter with an EF of 25%, he will have at least improvement of absolute 10% increase in ejection fraction. But it will take some time because he has a burnt out LV, dilated LV with the burnt out disease. So though we have reduced the QRS duration, this particular case will take a long time, like 2 or 3 months for seeing a visual improvement in LV ejection fraction. So this was a case where the left bundle lead was inserted and the CS lead was inserted. So this left bundle optimized CRT, where you are going to use a left bundle lead along with the CS lead or along with an RV septal lead. Even RV septal lead can be used, or a CS lead, RV lead, and a left bundle lead. So all these three leads can be clubbed together to have a left bundle optimized CRT. So that means that you are using a left bundle pacing as well as one more lead, either in the coronary sinus or in the RV septum, to have an optimized cardiac resynchronization therapy. This is going to be the future. See, in a non-ischemic cardiomyopathy with a typical LBBB, definitely either a his bundle pacing or a left bundle pacing is going to reduce the QRS duration. Or at least in 90% of the cases, you'll be able to get a narrowed QRS. But in other patients where you're having an ischemic cardiomyopathy, where you're having an intraventricular conduction defect related cardiomyopathy, where the QRS is very wide, it will not fit into either LBBB or RBBB, definitely your conventional CRT or left bundle pacing or his bundle pacing alone is not going to work. So you have to club it together. So which is otherwise known as a his bundle optimized CRT or left bundle optimized CRT. So in his bundle optimized CRT, we are going to use a his bundle lead and a CS lead. In left bundle optimized CRT, you are going to pace the left bundle as well as the CS lead. So clubbing this together will produce further reduction in QRS, further improvement in resynchronization therapy, and further improvement in patient's clinical symptoms. So you have to use both these things together in patients who are typical non-responders for a conventional IV therapy. Of course, we have talked about this Ismail pacing in the last week. When I said I was talking about this late rising threshold, lead dislodgements, battery depletion. So all this can happen with the Ismail pacing. So this one of our patients where we did actually Ismail pacing last year came with the rising threshold almost after a year. So it was done in the last year, and he came in this COVID era in a couple of months back with a rising threshold. The threshold was almost close to 7 volt. This was a non-selective Ismail pacing. So 7 volt in a complete heart block patient without an RV backup pacing lead is not accepted. So this was his lead. There was no change in lead position, though there was some reduction in loop, but his capture threshold was very high. So we had to put one lead in the left bundle area, and the capture threshold was beautiful. I can tell you the left bundle threshold will almost always be less than 0.5. So this particular patient had a left bundle threshold of around 0.5. And then we extracted that his bundle lead. And this is the QRS which we got. This is almost like a normal appearing QRS. So even in his bundle failure cases, then just simply extract the his bundle lead and put a lead in left bundle page. So far I have discussed about all the goods of left bundle pacing, but there are certain flaws and complications which you can expect in left bundle branch pacing. So we had a case where the patient developed a transient ST elevation in lead 1 and AVL with a reciprocal ST depression in inferior leads. So what we thought was probably we could have crossed the septum. So we know that we have to place the lead just in the left ventricular subendocardium. So if you are going to cross the subendocardium, and if you are going to expose the lead into the left ventricular cavity, there is a chance that the thrombus may catch here and it may embolize into the systemic circulation. So probably that might have happened in this case. I was trying to pace the left bundle. I think probably my lead might have perforated into the left ventricle, or even the sheath might have perforated into the left ventricle. So either a thrombus or an AR might have embolized into the coronary circulation. She had a transient STEMI, which lasted for 3 to 5 minutes. Then he settled immediately, and I could complete the procedure and got a beautiful QRS. I did an angiography immediately after doing the procedure. I couldn't find any lesion in the or any thrombus in the coronary. So what I thought was maybe I could have produced some spasm in the septal coronary arteries. So that would have produced an intense vasospasm and a STEMI, or there may be embolization of either a thrombus or air into the coronary circulation. So these things can happen while doing the pacing. So you have to be very particular in keeping the lead in the subendocardium. So your lead should not cross into the left ventricular cavity. You have to keep everything in the left ventricular subendocardial area. So these are experience. So I've told about our Ismail experience last week. So I'll just talk about our left bundle experience. We've done so far around 231. So 181 at our center and 50 at other centers as a proctor. So predominantly I've changed from Ismail to left bundle last year. So from almost like from August 2019, predominantly doing a left bundle pacing. Close to 151 cases were done in our center. Apart from that, 45 other cases were done as a proctor in other centers. So published this, our Indian data in JAC recently. So this was a 1-year non-randomized single center observational study. And this included 100 patients where we could demonstrate a 93% success rate. And you can see here. So I was talking about the threshold. The mean threshold is 0.59. And at the end of 12 months follow-up, the threshold remained the same. The sensed R wave was 14. It remained the same. The impedance, there was a drop, which is expected. But the most important thing is the pace QRS duration, which was 144 at the baseline, was reduced to 110 after pacing. And the LV ejection fraction improved from 44% to 53% after the procedure. So there are complications. One patient had a subacute lead dislodgement. One had the coronary artery injury, which I showed a couple of slides back. There's one mortality probably related to respiratory illness just before COVID. We don't know whether it was a COVID. There's no lead dislodgement. So in Ismail pacing, we had at least 3 lead dislodgement. Here, there was no lead dislodgement, no late rising threshold, and no thromboembolic complications. So these are the merits of doing a left bundle branch pacing, where you could show that the success rate is very good and it's an effective strategy. As a replacement of cardiac resynthesis therapy, close to 70 patients we have attempted, we could achieve a success of around 94%, out of which a classical non-ischemic LBBB constituted around 41. The QRS duration was reduced from 155 to 113, and LVEF improved from 34 to 48%. We were a part of this multinational trial, which was presented in this HRS 2020 recently as a late-breaking clinical trial, and it was published recently in JAC-EP, where we have actually taken all patients who had on cardiomyopathy with an indication for pacing. So the inclusion criteria includes an EF of less than 50%, with an indication for pacing either as a cardiac resynchronization therapy or even a conventional ventricular pacing for a complete heart block with LV dysfunction. We could show that the QRS duration could be reduced with an LVBP from 152 to 137 milliseconds, and LVEF improved from 33% to 44%, and we could see show an improvement in NYHA function class from 2.7 to 1.8. So if you see the CRT trials, majority of the CRT trials will tell you that patients with an LVBP morphology will have a better chance of getting a good result as compared to those patients with a non-LVBP morphology. Similarly, even in our study, what we could show was patients with an LVBP morphology had a better reduction in QRS duration, better improvement in LV ejection fraction as compared to those patients with a non-LVBP based in QRS morphology. So the word of caution, we know that LVBP is a recently evolved technique. So the first procedure was done in 2017 by Dr. Wang of China. So from there, the therapy has evolved. Now centers in US, centers in Europe, centers in India are extensively doing left bundle branch pacing. But the problem is it's a recent technique. There is no long-term safety data available. And the lead actually is not meant for a deep septal pacing. So this 3830 lead is actually an FDA-approved lead since 2005. And it was actually used for a site selective pacing. So you can use it for a ventricular septal pacing, or you can use it for an atrial septal pacing for capturing the Bachmann bundle. So all these things can be done with this lead. And this lead is in market since 2005, but it was later adapted for doing his bundle pacing and subsequently for left bundle branch pacing. So the long-term effect of the lead, since you are burying the lead inside the septum, you are almost 10 millimeter of lead is inside the septum. So we don't know what this myocardial contraction is going to produce the insulation problem to the lead. So that and all is the data is awaited, and you have to keep the potential complications. There may be a chance that the lead may dislodge into the left ventricle after 1 or 2 months. In fact, there is a case report where the lead has dislodged into the left ventricle after 1 or 2 months, after 2 months by Dr. Parikshit in US. So that has to be kept in mind. And thromboembolic complication, like in our case where we had a transient STEMI during implantation. So all this you have to keep in mind before adapting this as a widespread strategy. So to conclude, we have an excellent armamentarium of tools for doing physiological pacing. So you can capture the his bundle or the left bundle. Remember, there are certain limitations of his bundle where there may be a chance of rising threshold, lead dislodgement, battery depletions. So we have an excellent alternative. So only problem available, the only problem of this alternative left bundle branch pacing is going to be the safety data. Of course, probably in another couple of years or so, we'll be getting a good safety data of left bundle branch pacing so that it can be widely adopted. Thank you.
Thank you, Dr. Shunmuga. Again, great job, a fantastic talk on left bundle branch pacing. So let me ask you one thing, that in the current era, when there are so many residents and fellows, what would be your choices, or what would be the conditions where his bundle pacing would score over left bundle branch, or where would their choice remain, in the present era? What should be their answer if they are asked this?
Yeah, so ideally, when we are doing a conduction system pacing, the ideal way, I think last week also we discussed, is to begin from his bundle. And because his bundle is going to activate both left bundle and right bundle simultaneously, and it is going to activate both right and left ventricle simultaneously. So you will not have this interventricular dysynchrony. So an ideal way to do a conduction system pacing is to do his bundle pacing and look for capture threshold. If the capture threshold is less than 1.5 volt, you can accept this and come out. But if the capture threshold is more than 1.5, then you have to take out, because you cannot accept a capture threshold of more than 1.5 when you have an alternative. So once it is more than 1.5, you can probably go down to left bundle and screw the lead there. So this is a practical way of doing. But clinically, if you ask, since the lead has a good stability, and in a patient with a LBBB, dilated cardiomyopathy in LBBB, the his bundle is going to have a correction rate of success rate of close to 60 to 70%, but the left bundle pacing will have a success rate of close to 90%, and it is going to have an excellent lead stability along with a low output, low pacing output. So in a patient with a DCM LBBB, preferably you can keep the lead in left bundle because you have an excellent stability. You will have an excellent stability, and you can keep the battery at low output, and probably you can come out with a dual chamber pacemaker. But in patients with an RBBB, Even though I've showed good examples of correcting RBBB by doing left bundle branch pacing, it's better to start from his bundle, because correcting an RBBB by his bundle pacing is going to have a good result as compared to a left bundle branch pacing. Of course, in IBCD, it's anybody's guess. You can place the lead anywhere in his bundle. You can try, you can see left bundle. Probably you can see the better QRS from either his bundle or left bundle. But in patients with an RBBB, at least, if you want to choose one particular group of patients where his bundle is a must, trying a his bundle is a must before going left bundle is going to be an RBBB, because correcting an RBBB by his bundle is going to be more physiological rather than correcting it by left bundle branch pacing.
So you would always recommend that, it is always good for a person to start initially with the his bundle pacing.
Yeah, it's always better to his bundle. His bundle is a more, it's a complex procedure, and it involves learning the electrophysiology aspect of the conduction system more as compared to left bundle, because left bundle is just simple. You just go into the proximal septum, place the lead deep there and see the parameters. But his bundle needs understanding the electrophysiology. So if you want to learn conduction system pacing in toto, I think better to start with his bundle. Then you can move down to left bundle if you're not comfortable.
Dr. Sumod, Dr. Ankit, if you have any comments and anything. Obviously, one of the questions is lead retrieval after LBB. You rightly mentioned that, we still don't have data on that. So probably we are waiting for the more data. LB, light bundle branch pacing for valvular, non-valvular AF. I don't know.
So in any AF, if it is refractory, if you have labeled it as a permanent AF, where there is no solution for treating the AF, then probably you can see whether you are able to control the rhythm with the minimum drugs. Because with the advent of physiological pacing, definitely you can boldly ablate the ABJ and screw the lead in the his bundle or left bundle and have a better control over the ventricle in terms of controlling the rate. If you have determined that the patient is having a permanent atrial fibrillation. Among his bundle versus left bundle pacing, in his bundle pacing, so we are placing the lead in the his bundle and we are going to ablate the ABJ. So it's going to be probably a matter of 2 to 3 millimeter between the ablation catheter and the pacing lead tip. So there is a chance that while ablation, see what we usually do is we'll screw the lead in the his bundle or left bundle, then we'll come down to the groin and we'll ablate the ABJ. So that's what in the same setting itself. So once the lead is secured, all the parameters will be good in the his bundle zone. But once you are ablating the ABJ, you can try to ablate in the AB node just by coming back from the his bundle zone area, but still there is a chance that you may injure the pacing lead. So at least in a couple of cases in Dr. Vijayaraman's paper, so they have shown that there was some rise in his bundle capture threshold after ablation. So there is a chance that you may injure the pacing lead. But in left bundle, the lead will be in the proximal septum. You have an enough margin. In the picture which I have showed, I could show at least a 20 millimeter difference between the lead tip as well as from the ablating catheter. So you have enough margin for ablating the AVJ when you place the lead in the left bundle. So probably here, if you are not comfortable in having a good margin of ablating the AV junction, then probably you can go to left bundle so that you can have enough margin of ablating the AVJ.
Sir, usually how many turns do you give to your left bundle lead?
So if the septum is normal and if your sheath is giving a good support, so the sheath and the septum should be 90 degrees. Suppose imagine that this is your septum, your sheath should come like this and it will sit exactly at a 90-degree angle. So if this is actually satisfying, then probably you can give 4 or 5 rapid turns. So this 4 or 5 rapid turns will drive the lead and body into the septum and it will go into the desired area. But if there is any desist segment, if there is any septal fibrosis, or if there is a scarred septum because of any old ischemia, old active LMI, then the lead will not go that easily. In that case, you may have to turn the lead multiple times. So it's better to see in Ilevo view. It's not the number of turns, but it is the lead tip and its relation to the LV cavity, which is more important. So always go to Ilevo, and we usually measure the septal thickness just before the procedure. So I measure myself, whatever be the report which was given before, I usually see the septal thickness and I make sure that I know the number. Suppose if it is 10 millimeter, then I'll make sure that while giving turns, I will stop if my lead is going at least 10 millimeter to the septum, 9 or 10 millimeter to the septum. So it's better to have a control over the movement of the lead in the Ilevo view by giving the turns. And if it is a normal septum, it is going to take at least 4 or 5 turns.
So is there any lower limit or upper limit of septal thickness for which we should be more cautious?
There is no specific limit cutoff given. So we have done cases with the 20 millimeter septum. We have done cases with the 7 millimeter septum in adult. But if the lower, the thinner the septum, there is a chance that it may even form. Suppose if the septum thickness is 4 or 5 millimeter only because of scar, one thing is that with the scar, the lead will definitely not go in. So that I can assure you, if there is a scar in the septum, the lead will not go because the currently available lead will not penetrate that easily into the scar. But still, if you are able to penetrate it, very thin septum, sometimes there is a chance for dislocation. But there is no, currently there is no numbers for a minimum septal thickness to do the procedure. You can attempt it in any, but make sure that there is no scar, because with the scar, you'll not be able to penetrate it.
So, one more question. Other than fluoroscopic landmark, there is no other way to decide in which area we want to go. We have to just go 1.5 centimeter distally from the his bundle. That is the only fluoroscopic landmark.
Yeah, that is how the conduction system anatomy will usually look like in majority of the patient. But we have a lot of variation conduction system anatomy where there will be a high branching of the his bundle. So his bundle usually branches as it reaches the interventricular crest. But sometimes it may even branch in the membranous septum itself, where you will have a high branching, or even sometimes it can have a low branching. So that is actually very difficult to predict. But in majority of the patients, in RA, we have shown that conduction system anatomy in the RA view. So in majority of the patient, that is how the conduction system will be looking like. So you have to target in that initial 1.5 to 2 centimeter. But remember, if you have a scar in the proximal septum, we had at least in 3 or 4 cases where there was some scar in the proximal septum, or the ventricle may be bulging. You can see a bulging ventricle. Predominantly, the bulge will be in the proximal septum. So if there is a bulge, your sheath will keep on slipping, and you will not get enough support in that area. So in that case, what we usually do is, if you're not able to capture the left bundle, we can go a little below, like 2 or 3 centimeters below, and you can always capture the posterior fascicles. We know the posterior fascicle is also going to have a conduction system activation. So you can screw the lead there in the posterior fascicle. We can beautifully demonstrate fascicular potential. And once you pace the ECG, you will be able to see a fascicular block ECG on the fascicular block pattern on the surface ECG. So capturing the fascicles are also useful in terms of avoiding the RV pacing related complications.
Okay. So if we fail at the first attempt, then if we want to reattempt with the same lead, then we have to remove the lead, wash it, or we can continue with the same position.
Yeah, I usually, if I've screwed the lead deep in, and if I found that I'm not happy with the parameters, I will remove the lead and I'll remove the tissues from the lead tip, so that the further advancement of the lead while doing the second attempt will not be hampered. Because a tissue at the lead tip might hamper the movement of the lead while doing a second attempt. It's always better to take out the lead, just remove the tissues with a 2 ml syringe and with a needle gauze, and remove it, and then redo the procedure.
Okay, and one last question. At what step we should use the contrast? Can we use it beforehand to confirm our location, whether we are abutting the septum or not? Or in the end, just to confirm whether the lead has penetrated, we can use the contrast?
The initial use of contrast is not warranted, because if you are giving a counterclockwise torque and if your sheath is remaining stable, probably you can go in LA1 and see whether the sheath is moving along with the septum or it is moving dysynchronous with the septum. So usually when your lead is strictly opposed to the septum, the lead will actually move along with the septum. If that is seen, then there is no need of putting a contrast. I never usually do this contrast injection before the procedure or before screwing. So I usually do the contrast only at the end of the procedure.
Thank you very much.
Yeah, very impressive narrowing of the QRS. I know what is the usual learning curve, how it is technically very difficult to do, or it's a long learning curve.
It is actually easier than doing a Ismail pacing. In fact, it's nothing but an improvised version of a septal pacing. So in usual septal pacing, you're going to give a lead tip of 1.8 millimeter into the septum. That's what the usual helix length is going to be. Here we are going to give at least 8 millimeter of the lead into 8 or 10 millimeter of the lead into the septum. So there are only 2 or 3 rate limiting steps which we have to learn for doing a left bundle branch pacing. So that takes probably 2 or 3 cases. After that, probably you can start doing the cases on your own. It's not that difficult as compared to his bundle branch pacing.
There's a question how we can explain the right bundle branch block getting corrected, the QRS getting narrowed when you're pacing the left bundle.
Yeah, so actually in a patient with right bundle branch block or left bundle branch block, so let us say in left bundle branch block, the accepted HV interval is probably up to 60 milliseconds, though the conventional teaching is like 35 to 55 milliseconds. The LBBB, the abnormal HV, usually tell if it is beyond 60 milliseconds. So in a patient with a DCM LBBB, if I'm going to see an HV interval of 70 or 80 milliseconds, then I'll be happy because it is more of an electrically created problem. That prolonged HV is a contributory factor for the LBBB. And if I'm going to correct that LBBB, I'm going to revert the patient's LV function. Similarly, in RBBB, if I'm going to see a prolonged HV, the one case example which I showed an HV of 65 milliseconds. So if I'm going to show that the HV is prolonged, that means that there is some conduction system problem, because in an usual RBBB, HV interval will not be prolonged. So we usually have a RBBB with a normal HV interval. But if an RBBB is having a prolonged HV interval, and if there is an associated LV desynchronous contraction, that means that there is some additional problem in the left bundle also, or in the distal conduction system also. So if you are going to capture the left bundle, you are going to activate at least the left ventricle in a synchronized way. Because many of the patients with the prolonged HV and RBV, you will be able to see a desynchronous contraction of the septum. So if you are going to capture the left bundle selectively, and if you are going to get a good left ventricular activation time, at least your left ventricle will be contracting in a synchronized way. So that will in turn contribute to the improvement in LV ejection. But definitely, at least in CRT population, we know that an RBBB is a poor candidate for CRT. We know that trials have often shown that RBBB patients won't respond as good as compared to LV patient in a conventional BIV therapy, BIV CRT. So at least with the advent of this physiological pacing, we can try this, and we can probably see whether we are able to narrow down the QRS with a good LV activation time and do some benefit for the patient.
Okay, Dr. Madhu is asking one good journal and book from residents' point of view. Dr. Shunmuga very clearly mentioned that there's a landmark article on physiologic pacing, his bundle pacing by Dr. Vijay Raman and Jack. You can read them. And the lead bundle branch pacing, just Dr. Shunmuga himself published a review article, and you can read that. So these are good initial articles. Besides, there is another 2020 article published in JAHA, Journal of American Heart Association, which is again a very comprehensive and a simple review on conduction system pacing. So there are quite a few articles, and you can read them. It will develop your interest, and I would suggest that you read them early after the lectures, so that will make more sense and more corrections for you. So a lot of people have participated and appreciated, and I believe that when you get to do these things, the questions that in the mind and the apprehensions are clarified. And as Dr. Shunmuga rightly mentioned, that 2 or 3 cases what is required initially to remove that initial hitch, and his bundle definitely requires a little bit more patience and learning curve. But let me tell you, Dr. Shunmuga, that it's been a terrific learning over the 2 sessions. And thankfully, we had 2 sessions, because this would not have been justified otherwise. And stepwise, we could easily go along with you on this journey. And the most important compliment that we have got, it's actually yours, is that you have kindled the interest in such chapters, such topics, for those people who are least interested in this. So this is the art of teaching, and this is the beauty of the COVID times and the distant online learning. I really thank you on the behalf of CSI and the PG track and all the residents. We have more than 200 people who are live today on YouTube and on this channel. But let me tell you, we are not going to leave you with the kind of teaching skills that you have. We'll keep on bothering you in the near future as we are going deeper into the electrophysiology and these concepts, and believe that you would also enjoy interacting with many of the residents. From next time, we'll have some good quizzes also. We will have some good residents on board also, as the times and the new batches are joining. So really, I thank you for joining us today, and all my friends, my colleagues, Dr. Sumod, Dr. Ankit, thank you so much joining. Thank you, Intas, for giving us this nice platform. And this old year is passing with some interesting and different memories. And I believe that the new year, next week when we are going to meet, we are meeting in the new year, and that is going up, bringing its new opportunities with us. And I believe that our positive vibrations and our positive thought process will transform everything. So a lot of loving wishes from the Delhi CSI, wishes for a very happy new year. Please stay safe, have a nice and a wonderful celebrations, and have a very happy and a joyous life. Thank you all, everyone, for joining today on this last webinar of this interesting year. And next week, we'll catch up with some interesting topic again. Till then, goodbye and have a great weekend and great evening. Thank you. Thank you so much.
Thank you, sir. Thank you.
Thank you. Thank you, Dr. Shunmuga.